So we have been talking about mainly about palliative care and pain management. Now we will move on to another important topic, which usually have been it is not taught during our medical schools, uh, even during MBBS or specialty or super specialization. But now it has been introduced into undergraduate curriculum, and we know that communication is one of the most important aspect of patient care. But uh, we are not giving a proper importance for communication due to many factors. But I think if we give proper importance to communication, we can uh, we can actually reduce the stress between the society and professionals, and also it has many importance, and even it can improve the patient satisfaction. uh, so we will hear more about communication from Dr. Biju Raghavan. So Dr. Biju, as the consultant and the head of palliative medicine department at Rajagiri Hospital, Kalamassery, and Alva, and he has done his postgraduate diploma in pain and palliative medicine, uh, and he has uh, more than 17 years of experience in palliative medicine, and he's also one of my best friends. Uh, we have been working together for more than 10 years. So it's over to you, Biju.
Thank you, Sunil. Thank you for the kind introduction. We have been working together since 2004 when we joined as young postgraduates. In fact, that was the first PG program in the country. And we both have traveled a long way. And it's a pleasure uh, uh, seeing you and associating with Palim India. Palim India has a special place in my heart. And I would also like to welcome all the participants who are joining in this program from across the country. And I think without much ado, we should straight away start. I would request Arun to please start sharing the screen. Right, as Dr. Sunil mentioned, I am Dr. Biju Raghavan. I am a consultant in pain and palliative medicine at Rajagiri Hospital, which is in Kerala, in the central part of Kerala, in the district of Ernakulam. So we are going to do this communication skills training program in two parts. Today we are going to do part one, and subsequently at a later date we will be doing part two. In part one, we will be primarily talking about some very basic aspects of communication, and hopefully we will build upon it in part two at another day. Can we? Can you go back, Arun? I mean, I just want you to be on the
Uh,
second slide, please.
Biju,
Yes.
I think there is some problem between Arun and you. Probably the coverage in your place is very poor, so that I can see he's moving the slide. So when you
Okay.
told that it's next, then he moved it and then came to third slide. So
All right.
yeah, we
Okay.
can
So,
go.
Arun, can you hear me clearly?
Yes, sir. Yes, sir. Sir.
Okay. Right. Oh, sure. So probably we are good now.
Okay.
So we'll just talk about why it is important to learn communication skills as healthcare professionals, doctors, nurses, or any kind of professional in the healing arena. We'll talk about what are some of the barriers to communication. We'll talk about some of the do's and don'ts, and we'll also talk about how we must revamp our history take. We have been taught how to take a history when we were young medical students. We'll see how we can hopefully try to improve upon it. Next slide. Right. So to begin with, why would somebody come to a hospital? They come because they are not well, they are ill, and it is a negative point to start with. You would go to a cinema theater or a resort or a place of leisure because you are in a positive frame of mind. But you would never go to a hospital in a positive frame of mind. You go there just because you have to, because you are suffering, you are in pain, you are not well. And that is the challenge. This is our profession. And we have to start dealing with people from the point of negativity. So the negative energy is what we are dealing with to begin with. And that is what makes our profession such a challenge. And also, you may have a lot of facilities in your hospital. You may have the latest gizmos. You may have people with excellent qualification, but ultimately, just like beauty is in the eyes of the beholder, whether the satisfaction was there or not, whether their experience was satisfactory, it is in the eyes of the patient and the family. And hence, we have to learn not only the science of practicing medicine, but the art of medicine, which is communication skill. And that is what this combination is what is going to give ultimately satisfaction that we have been taken care of. And this is the feeling we want to give our patient and families. Now, that is the challenge. Next slide, please. So there was this study in the Headache Journal. It's a very old study, but it is still relevant. It came in 1986. And what the study showed, the gist of it was the best predictor for resolution of headache turned out to be the patient's perception that they got an opportunity to tell their story to the doctor completely to their satisfaction during the first visit itself. So that ability of having been listened to, that is not only going to give satisfaction, it is almost therapeutic. Now that is the conclusion that was brought about by this, emphasizing the importance of communication skills and having been listened to. Next slide. And also, communication turns out to be a major, or rather, the lack of communication or miscommunication turns out to be a major cause of medical errors, anywhere between 60 to 70%. And these are completely preventable. It is just a matter of putting in proper systems of communication. Next slide, please. There is also a financial outcome for this. This study from US shows that hospitals on an average lose around $12.3 billion each year just because of inadequate communication. And hence it is something that we all need to look into. A lot of cases that goes into court, that is when people sue the doctors, majority of it turns out to be because of poor communication, inadequate communication. Next slide, please. And as we enter medical college and as young medical students and in our journey to becoming doctors and specialists and super specialists, all along our journey, we are constantly tested. Our knowledge is tested, our skills are tested, our problem solving abilities are tested. in the context of medical diagnostics, therapeutics, etc. But at least in the Indian context, there is hardly any place where our communication skills are tested. Our knowledge of communication skills, our practical ability on communication skills, these are some which are never part of our examination process. And as a result, we may turn out to be excellent clinicians, but our communication skills, unfortunately, uh, it does not keep at par with that. On top of that, we may have very limited role models as we grow from medical students to doctors and senior doctors. So many times we learn few lessons the hard way, and sometimes we never learn lessons which are important. And it is the problem with the way our medical education is structured, where little or no emphasis is placed on the very crucial aspect of our medical practice, which is communication skills. Next slide, please.
Sir, can you see the next slide?
What I have in front of me is headed testing clinical competence.
No, sir, it's already changed. That one, next slide, doctor-patient relationship slide. Sir, can you turn off your video, sir? Sir, can I turn off your video, sir?
Sorry?
Sir,
Yeah.
can I turn off your video?
Yes, please. Please do. So the importance of communication is most crucial when it comes to the doctor-patient relationship. I would add the doctor-patient family relationship. So it is crucial when you have a good communication, better communication, your diagnostic accuracy improves because we have all been taught as young medical students the importance of history taking. So good communication improves your ability to dig out more information, and more information means your ability at your ability to on diagnostics improves. And equally importantly, when you are prescribing some treatment, if the patient understands why you're prescribing what you're prescribing, then the compliance is going to improve, and the patient satisfaction because of that will improve, because when you have better compliance, you will have better clinical outcome. And when you have a happy patient and a happy family, you will have a happy team. Your medical team will be less stressed if your patients are happy and the families are happy. This also has a bearing on patient safety, as we talked about earlier, and also reduces your stress because the chance of you getting sued comes down as your ability to communicate improves. Next slide, please. So I guess you would have already, got the answer to this by now. Why should we learn communication skills? Why should we learn enhance our medical communication skills? Next slide, please. Because it is beneficial to us. We should learn communication skills for our own selfish interest. Because when you become better communicators, your compliance, your patient's compliance improves, your medical management will show better outcome. And that happens only if the patient complies with your management. And as a result, you not only have better relationship with the patient and families, and as a result less stress, but also your how your colleagues will view you will also be affected. When your colleagues see that your patients hold you in high esteem, and and your patients stick to you. They are not jumping off to see some other people. Naturally, they everybody will see that they will hold you in highest. So it is a win-win situation for you as a doctor, as a healthcare professional, for improving your communication skills. Next, it is also going to benefit to the patient and family, as is to be expected, because it gives them some clarity on what is going on, or at least clarity on the fact that your doctors are trying to figure out what is going on. And it gives them a sense of direction. They know what to expect and what are the possibilities in front of them, and how long it may take to diagnose a condition, how long it may take to treat, or we really don't know how long it may take. So at least that kind of clarity will be there, and it helps them plan financially and otherwise. It helps them plan how to go ahead with it. So definitely it helps the patient and the family. Next slide, please. And as a society, there is definitely a lot of distrust, a lack of trust between them and us, the healthcare professionals. And it is important to bridge the gap. And it is our responsibility to bridge that gap. And the best tool to bridging that gap and earning the trust of society is to be better communicators. There are a lot of misconception about what medical science and technology can achieve. So we have to bring their expectation to the realistic level. And we can do a lot of things when it is realistic, but we can't do much if their expectation is way beyond what medical science can provide. And that is where the conflict happens. We are often not able to bridge the gap between expectation and reality. And good communication skills helps you do that. Next slide, please. So, what are the barriers to good communication? Let us see. Let us figure out some of them. Next slide, please. So, a lot of miscellaneous barriers which are put as environment as a barrier. Can you have the next? There are a couple of bullets. 1, 2, 3, 4. One more, right? Yeah. Can you go back? Yeah. This. So, lack of time is often stated as a barrier, but please understand that good communication is supposed to save you time, not increase your time consumption. Good communication should save you on time, energy, and effort. That is what good communication should do. If it is not happening, then probably your communication skills need to be improved upon. Because the whole purpose of learning good communication skills is to make your life easy. So good communication skills is supposed to save you time, energy, and effort. And also another barrier could be, especially in very crowded environment, lack of privacy could be an issue. So we must learn some techniques of how we can create an illusion of privacy, even if actual privacy is not there. And that is how we get over that barrier. We have to rearrange our furniture sometimes so that the physical barriers of too many things cluttering the eye contact can be taken care of. And sometimes we may not be able to do much about the ambient noise, but definitely mobile phone is one major noise polluter and a barrier to communication. And a simple answer to that would be we have to learn and enforce telephone etiquettes. Nowadays, because of COVID, a lot of our consultations are moving on the telemedicine platform, and more people are using technology. But please remember, everybody may not have access to technology. And even if they have access to technology, it is possible that they may be technology agnostic. They may not know how to use the technology. So that can be a barrier sometimes when The only way people can reach medical professional is through technology, and if you don't know how to use it, definitely that becomes a barrier. Next slide, please. Sometimes the patient and or the family can be a barrier. Sometimes when the patient are coming from a very what do you call socioeconomically uh, uh, what do you call limit socioeconomically backward background, they may find themselves overwhelmed in your presence, and they may find it very difficult to communicate everything that they want to, because they may be very timid, or they may be very scared, and sometimes they may feel that you are very busy. It could be the signals you're sending out from your body language, but if they feel that way, and then they may curtail whatever they wanted to tell you. And many times they may think that it is not appropriate to tell the non-medical problems that they are facing. For example, financial issues. Remember, if you know the financial stresses of your patient, you may reconsider your prescription into from the best prescription to perhaps the most practical prescription. And just this change, if they can't afford your best prescription, the outcome will not be satisfactory. But if you make it an affordable, practical prescription, you're definitely going to get a better outcome. So it isn't the best prescription, but the most practical management strategy that you have to employ. And for that, you need to be a better communicator, because better communication will give you more information, and information and knowledge is power. There are some diseases which affects communication, diseases which impedes speech or hearing. So then we have to, you know, uh, find out ways and means of circumventing those barriers. I'm sure many of you would be doing it on a daily basis as well. Next slide, please. And how about us? Can we ourselves be a barrier to good communication? So let us see that. Sometimes our appearance itself may be scary to the patients and family, especially in these days when we are covering up our faces with masks, and sometimes we are in PPE kits and all. So these things may appear very scary to the patient and family, but then these are inanimate objects. It is us, the human beings inside this mask and the PPE kits, that we have to behave. That is not only what we say, but how we say, and including our body language, which will uh, really take care of the fear. Next slide, please. And sometimes our attitude can be a problem. Many times we feel that the only thing important are the clinical data, learning all the clinical information and the clinical skills. Next slide. There are a couple of bullets in. Yeah. Can we go back? So it is very important to understand that communication skills is the way you convey your knowledge and how you want this to be applied to your patient's care in a language, in a method that can get across to them. Otherwise, whatever be your knowledge, skill, and the sophistication of it, if you are not able to convince your patient and family about it, they will not comply. So then what is the value of your knowledge if you are not able to get the clinical outcome that you can potentially get, but it's just not happening because of the patient and family not being compliant? We all know about situations where patients go from one doctor to the other, and to from there to the next doctor, because many a times what happens is they just don't understand what is being conveyed to them. They may sit in front of you and shake their head in understanding to all the message that you're conveying, you may be spending maybe half an hour in telling them all the options that they have. But when they come out of the office and they say, uh, I didn't understand what the doctor was saying, then the time, energy, effort, the knowledge, the skill, all that has been employed by you becomes waste. And we just cannot afford to have that kind of wastages in our clinical practice. And hence, if we have an attitude that communication skills is not important, we need to sit up and smell the coffee and be ready to change. Because the world is changing. If you don't want to change, be ready to be left out. Next slide. Now, this is again what I was talking about. Training, structured training in communication skills is lacking in our country, and many of the developed countries they are putting in hours of communication skills training program. And in many countries, example in UK, communication skills training program starts even from the preclinical uh, uh, time, and they are dedicating almost more than 40 hours of communication during their basic medical education. And the communication training program continues on post graduation and super specialty level. It is an ongoing enhancement of knowledge and skill. Whereas in our country, we may not have had even one single class on communication skills all through our uh, medical education career. And that is a huge loss to each one of us. It is not our fault that we end up in trouble. It is the system which is letting us down. Next slide, please. So just coming to some of the do's and don'ts. So don't avoid eye contact. In fact, I would encourage to make eye contact. And even if you're wearing a mask, do smile. Just don't be grumpy, and because if you're grumpy, it will show in your voice. If you smile, that will also show in your voice, and it will show in your eyes. So even if you're wearing a mask, do smile and do make eye contact. Next slide, please. Stop categorizing or labeling people. It is very important to be non-judgmental. People are from different backgrounds and they have different perspectives. You may or may not agree with their points of view, but don't categorize them as so they are difficult kind of patient, or this patient is a VIP problem, that patient is a very itchy, irritable character. People will have so many reasons for behaving how they are behaving. We, as each one of us, we know we are not in the same temperament in 24 hours. Within 24 hours, sometimes we are happy, sometimes we are miserable, sometimes we are angry, sometimes we are envious. So within 24 hours, we keep changing our colors like a chameleon. Why do you expect others to be uniformly nice and uniformly accepting of what we are saying? People are different, and expect and accept people as they are and respect them for who they are. Uh, for example, if the patient is a cobbler or is a fisherman or is a chartered accountant, doesn't matter. You as a doctor, for from your point of view, that's a patient, and you have medical knowledge and skill, and the cobbler has the cobbler's knowledge and skills. It is not interchangeable, right? So that person knows a few things more than what you know. That person can do a few things that you can't do. So everybody brings their own knowledge and expertise to the table. Nobody is bigger, nobody is smaller. We are all the same. And as a medical professional, as a doctor, doesn't matter the background of the person, doesn't matter the profession of the person sitting in front of you. It is very important to respect everybody equally. Next slide, please. So this is something that we often see ourselves doing. That, for example, your pain is better, isn't it? So when you ask the leading question like that, then it becomes very hard for the patient to say, no, no, I still have the pain, because you are in a superior position, because you are the caregiver and they are the care receiver. And this position is never equal. Doesn't matter what is the socio-financial position of your patient. Even if the patient is socially or financially above you, but in the hospital environment or in the healthcare environment, you are at least one step above. So the relationship is never equal. But when you say your pain is something better, aren't you feeling better now? When you say things like that, if not all, at least some people will find it very difficult to deny it. They may not be able to say, no, I am not feeling better. No, my pain is not better. No, my blood loss is not better. No, my anxiety is not better. So they may not be able to say things like that. So it's very important to never ask questions in a leading manner. Always ask questions in an open-ended manner. Next slide. Do not minimize anybody's suffering. Just saying, oh, this is nothing. Look at, other people who are in this kind of situation. So do not minimize, do not compare. From your point of view, that person's problem may be a small problem, but from that person's point of view, his or her problem is the only problem in the world. So we have to have empathy. Empathy means see people from their point of view. Imagine how it feels to be in their shoes. Imagine how it feels to be in their position. And please understand, for each person, their problem is the only problem, and their problem is the biggest problem. So don't minimize their problem, don't compare the problem. Acknowledge that they are suffering, acknowledge that in their situations, anybody would feel this way. Basically, what we are acknowledging and normalizing is not the situation. We are acknowledging and normalizing their emotional experience of the situation. We are acknowledging and normalizing their emotional experience of the situation. We are not saying that the situation is minor or the situation compared to another situation is nothing. It is not a big problem. We are not doing that. We are saying that you in this situation feeling this way is perfectly okay. It is understandable. And anybody in this position would feel like this. It is normal to feel like that. So that is the difference. Next slide, please. Never give false hope, because people hang on to every word that comes out of your mouth. And just because you don't know how to speak the truth in a sensitive and empathetic manner, the escape route cannot be telling lies. So never give false hope, give realistic hope, and that is a skill that one has to learn, how to give realistic hope. And if you are also learning the principles and practices of palliative medicine, I can assure you it will so much empower you that you may have limitations to cure, but there is no limitations to care. As a palliative physician, I have never had an occasion to tell any of my patients or their families that there is nothing more to be done from my side. Even if from a normal doctor's point of view, it may be the most hopeless situation. As a palliative physician, there is nothing like a hopeless situation. There is always something to be done. But for always something to be done, we have to start from the point of reality. So realistically, there is a lot to be done. And that's why I said earlier that we have to be honest and bring the expectation to reality, because from there we can do a lot of things. So don't give false hopes, always give realistic hopes. Next slide, please. Do not assume. It is a it's a habit that we all have, and it is very difficult to overcome it. So I can only say that it's very important to ask anything that the patient. I am so scared. Don't assume why the person is scared. Ask the person, why are you scared? And when you ask, the person will tell you. And when the person tells you, then you will know why the person said what the person said. Never assume, ask, and you will get to know. It is as simple as that. But it is very difficult to put it into practice because we are so much, what you call, habituated to assuming. It is very difficult to get out of that habit and start asking. So I implore you, ask whatever the patient says. I am so scared, I'm so sad, I'm so worried. Ask them, why are you scared? Why are you worried? What are you worried about? And then they will tell you what they are worried about. Next slide, please. Well, last but not the least, do not forget the human touch. It is the most powerful therapeutic tool you have, and you don't have to, buy any costly instrument for that. A human touch is the most powerful therapeutic. I know in these times of COVID, we are trying to not touch human beings, but I'm saying do not forget the human touch. You can put on your gloves and your PPE kit and mask and everything, protect yourself, but still do have that human touch. And most importantly, just like your patient's health is important, just like your patient's family's health is important, your physical and mental health is also important. So it is very important, especially in these stressful times of pandemic, that you take good care of yourself. For that, move your body, do some exercise, move your brain, do some meditation, move your spirit, indulge in some hobbies, and stay connected in whichever you want. You can stay connected to nature, do some gardening. You can stay connected to God. You can pray. Stay connected to other people, friends, family, relatives. Pick up the phone, do a video chat, do something. But always stay connected. If you are not interested in connecting to people, connect inwards, connect to inside. Ask, meditate upon who you are, what is the purpose of your life, etc. But have this process of being connected to something inward, outward, external, beyond this realm, to divinity, wherever. Next. So just very shortly about history taking. First and foremost, breathing. Make eye contact, smile, and nod your head along with the smile, and then you can say what is culturally appropriate in your area. You can say hello, good morning, namaste, namaskaram, whatever. And then next important thing is to become comfortable, physically comfortable, not only you, but also for the patient and family. So if you are in an OPD, offer a seat for the patient and family. If you have gone to the IP, find a seat or a stool or something to sit down by the bedside of the patient. It's very important to sit down, because when you sit down, immediately you are sending a message that I'm here to listen to you. You don't have to spend extra time. You spend whatever time you usually take for a round. It may be 2 minutes at the bedside, 5 minutes at the bedside. You decide whatever it is. But instead of standing, sit and have that bedside. Start the interview with an open-ended question. Don't start with how is your pain today. Just ask how are you, and then they will tell you not only about the pain, but also about anything else that they wish to tell. And the more you know, the more you can help. And once they start telling you the problem, do not interrupt. Listen. There have been plenty of research which shows that doctors start interrupting the patient within the first 10 seconds of the patient starting to speak. Next slide, please. And not only you have to listen, you have to encourage your patient to talk. by maintaining eye contact, you and also nodding your head from time to time, and also making some encouraging sounds like oh, okay, and then so this kind of encouraging sounds is important to help them to encourage to come out with more information and clarify as you go along. Sometimes what happens is that the patient may meander along to areas where it is really not relevant to the present line of inquiry. So sometimes you may have to clarify, what did you say that? Why did you say that? And in case they have, you may have to gently guide them to where you what you call to the relevant part of this conversation. But please remember, it is also important to know their social issues, financial issues. So please, please be curious about where all the patient wants to, focus on their concerns, and then ask them what do they understand about their situation. This is called insight. What the person understand about their situation. What does the person understand about their diagnosis? Sometimes they may know everything. Sometimes they may think that they know everything, but in reality, their understanding may be far off from the truth. Or it is possible they may know little bit of the truth. They may know, and some of them, the rest of it may be made up by their own imagination. It's very important to understand what they know, and then also find out what their concerns are, and along with what their concerns are and what their insight, what is this thing, it's also can we have the next slide please? It's also important that once we have this their insight and what they're worried about, that then we have an honest discussion, and that is sharing of information. Now remember, there may be situation where you maybe you don't have the permission of the family to tell the truth, but that doesn't mean you have to lie to the truth. There is a lot of gray area between the truth and telling a lie. So you can always say phrases like, I need to study this more to come to a conclusion, and maybe I'll talk about this later with you. Instead of saying, oh, there's nothing wrong with you. So, don't lie to people, but if you can't tell the truth, you can use phrases which will buy you time, and then you can always talk to the family and try to discuss with them and make them understand that it is important to be honest with the patient on these matters. Now remember, people have different kind of beliefs, they have different kinds of fears, and their social financial problems are very very unique to them. They may have many constraints, and as a result, if they are not able to agree to your line of management, the proposal that you have given, don't feel upset, don't feel angry, because people have difficulty. It is best to talk to them. You may have medical management in mind, but talk to them that, okay, this is my suggestion, but what do you think about it? And then let them come up with their point of view. And if in case you feel that, or in case you realize that they are not able to comply, then you give them another option, which may not be the best option, but perhaps might turn out to be the most practical option. So this kind of decision by sharing of information is called decision by consensus. It's a decision by consensus, not only from the medical point of view, but from the patient and family's point of view. Now, if it is a little long drawn out process, but it is in our benefit, because whatever be the outcome of that management decision that we have taken, the responsibility is between all of us, not just the doctors. So that is the best part about taking a decision by consent. So we are all the patient, family, their extended family, we doctors, our or the medical board, we are all in it together. And then in the end, summarize the interview and then close the interview. Next slide. And when you close the interview, before finishing, ask them, is there anything else that they want to ask? And this is the last sentence that you should be saying. After all the explaining and all the understanding, all the discussion, all the agreement, everything, in the end, you just say, is there anything else that you want to ask? Is there anything else you want to say? This brings a smile on the faces of the patient and the family. So it is like the dessert, the sweet dish at the end of the sumptuous meal. That when you let the patient and the family leave the room, you should leave them with a smile on the face. You should leave them, they should go out of your room with a little bit of positive energy, with a smile on the face. And just asking, is there anything else you want to say, or is there anything else you want to ask, will bring a smile to their face. And then you close the interview by leaving the door open. That means you provide them a contact number. If you do not want to give your personal mobile number, don't, because your private life is your private life, and that should be respected. But give them some number, some contact, your department number, or 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 call duty number, or whatever, something, so that they should not feel that, okay, we are going from here and now we can't contact for any important information that we want to. So always give them some kind of contact. And the last part is how we started in the beginning, greeting. So make eye contact, smile, nod your head, and then say goodbye, bye bye, namaste, namaskaram, or whatever, at what is culturally appropriate. So this would be my take on history taking 2.0. So I guess that is the end part. I think we don't have any more. Do we have any more slides? Can we have the next slide, please? Arun, can we have the next slide? Yeah. Okay. So medical communication is not a talent. I mean, if you want to sing or you want to write poetry and all, God has to be kind on you. You should get a superior quality brain to be creative, to be talented. But skill is something that any average person can learn. It is like how you learn to take blood pressure. In the first class of physiology, we learned how to tie the cuff, and it was so difficult. But afterwards, we can take BP even while we are sleeping, because we become so skilled. So communication skills, like any skill, is something that can be learned. Doesn't matter your personality. You may be introvert, you may be extrovert, you may know 10 languages, or you just know one language. Doesn't matter. It is a skill, and each one of us can learn it and practice it, polish it, and become good at it. Next slide. So I think next week we will be talking a little bit about communicating bad news, managing pollution, and then dealing with an angry person in the clinical environment. So I guess that's about it. We'll stop here, and I'll be happy to take any questions about this before the case presentation starts. Arun, if you have
Arun,
any,
please.
yeah, yes, please, yes, Sunil.
No, no. I was asking Arun to unshare the screen. He has done it. And um, if you have any doubts, please ask. Or your comments.
Hello. Hello.
Yeah, yeah, please.
Dr. Kale from Nagpur. To Dr.
Yes, sir.
So, I have put it in the chat box also. Is it important to know the education level of the patient and family, and their profession? Dr. Biju.
Hello, sir. Is there any particular reason you
No,
asked that
because
question?
yes, because I find in my daily practice that if you know the education level of a patient and the family, then I can communicate them better when I'm explaining the whole process. So, because for example, there was a motor mechanic in front of me. So when I wanted to tell him the process, so in his professional language, he can understand it better. This is my opinion. You may differ. So professional and as well as their education level, because of an totally uneducated person and an educated person makes a difference. This is my
Uh,
opinion. What's your opinion?
thank you for your comments, sir. I agree with some part of it, and I disagree with some part of it. I'll tell
Okay,
you what I
no
agree with
issue.
first. I'll tell you what I agree with first. I totally agree with what you're saying, that having understanding the background helps us to uh, communicate in a matter that they may understand better. We
That's
may
right. That,
use we may use examples which may make
yes,
sense to them. So I
right,
totally
right.
agree with that. Uh, and the thing that I don't agree with is that if somebody is uneducated and if somebody is highly educated, it will make a difference. The reason I say that is every profession has its own jargon.
Hmm.
For example, lawyers, when they speak, it may be very difficult to understand. As a doctor,
Yes.
I may not be able to understand, IPC so and so and so. They may
Uh,
go and continue saying, and it will all be over my head.
uh,
I have a couple of engineering friends, and when they talk, I don't make any sense. I have my chartered accountant who speaks a language which is very mysterious to me. I don't understand, despite being a doctor. So I assume when it comes to medical matters, whether somebody is uneducated or is a chartered accountant doesn't matter, because they will not be able to understand the medical jargon. So as healthcare professionals, we have to put the information in a language that they're able to understand. And that is where I agree with what you said in the beginning, in a manner that they understand.
that's
That
right.
has, I don't think it has got anything to do with education. Probably the
Right.
only difference would be if you're dealing with our fellow professional. And even there, I can assure you, if you're talking to, uh, I mean, uh, I don't know, maybe if you're talking to an obstetrician and a gynecologist and talking about hematology, or an orthopedician and talking about medical oncology issues, probably it's possible that they may not make sense to each other.
Right. I
So
got your
within the
point.
profession also, it's possible that if we use jargon, that
You're very right.
hello. So
You're very right.
yes, yes. Please go on. Please go on.
I got your point. Thank you so much.
Thank you.
Biju, there are some questions in the chat box.
In between,
Uh,
somebody else had spoken. I wonder if we could give an opportunity for the person who I think it was, I don't know, somebody else just came in between.
No, that was just a comment on what you said. That's all.
All right, yeah. Oh, right. Thank you.
okay. How to assess our communication in patient perspective? Any learning tools?
Why don't you talk about it, Sunil? Because your organizations are running a lot of training programs, so you can talk better about that.
Uh, I think only if you see what you have done, then only you can reflect on your communication abilities. So maybe if you ask in the clinical practice, if you ask somebody how you are communicating, because we may think that okay, we are doing perfectly fine, and after some time some of your colleagues may tell you okay, this is what I have seen, then only we will understand. So I don't know any other tools for assessing our communication, uh, but the communication, how to you can actually view the videos if somebody is communicating properly, and then uh, 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 there are two sets of videos. One would be the bad way of communicating, and the other would be the good way of communicating. So that way we can make out what are the points that we need to be careful. But if we want to assess our own ability, it need to be recorded. I don't know whether there is any other tools for that.
I agree with Sunil. I am not aware of any specific tool to enhance our clinical communication skills, but it is, as Sunil said, it is always good to take a feedback from our colleagues, provided they are also trained in communication skills. Otherwise, it will be a question of five blind men assessing the elephant and everybody coming with their own uh, diagnosis. So it's very important that at least people should have undergone some basic communications training program, and then we should help each other out by pointing out where all we could improve upon. And obviously, I would say that there is no point in feeling offended or bringing in our ego in that, because whenever we are telling somebody, please point out my deficiencies, because we want to improve. So that's the best way of going about it. In my department, in my team, I try to make a game out of finding out who is assuming. So in my initial days when my team was forming, we had a new nurse, a social worker, etc. So I taught them this communication skill, and then whenever I found that they were assuming something, I would just point it out, and it was like a game. You just find out, and in between I'll purposefully say something as an assuming, and then see whether anybody is caught me. And we have had occasions where my team members pointed out, you are assuming. So then it becomes a fun, and it's a fun way of learning. So whichever area that we want to improve, it is not enough that one person improves. Everybody in our ecosystem has to improve on communication skills. So once we all have our basic training, then we can make a game out of various areas so that we can improve by this method. So that's just one example that I can think.
Can I
Okay.
interrupt? Can
Please
Dr.
do.
Sunil Kumar?
Yeah.
So as Dr. Biju said, and Dr. Biju said in his lecture itself, patient's face and the face of the family when they're leaving your room after communication, if they're happy, that means your communication was perfect. That's what Dr. Biju told. And that's what I also believe. Agree, Dr. Biju?
uh, when I say that, is there anything else to that you want to say before you leave? That brings a smile, and I want to send them off with the positivity. But I will not assume that my communication was perfect.
I'm saying, sorry for interrupting. I'm not saying your face. The patient and their families, expressions on the face, that speaks of the good communication. This is what I practice.
Yeah, probably communication was good, maybe, but I will not assume that it was perfect.
Okay.
So
And my personal take is, there is nothing like achieving perfection. It is always a journey towards perfection.
okay. We will talk about breaking bad news in the next class in detail. And how do we deal with small subset of patients who don't want to leave your consultation room despite having answered many concerns?
Uh, would any of the participants would like to answer that? Maybe they have some techniques.
Anybody?
I think it is better that the person who has kept put the question should answer.
So most of you will be practicing and you might have faced this situation. So how are you dealing with the situation?
So I
Share that
think we have an answer coming in. I couldn't catch it totally.
Yeah, I politely tell them that we will discuss the next time.
So there we have an answer. So in my practice also, I employ somewhat similar thing. I politely tell them that we need to move on. So shall I ask the next person to next patient is waiting. So shall I now take them in? So and we will discuss more about it next time. So there are various ways you can do it, but the catchword is politely, without hurting them. So we have to be polite and firm, not polite and hard, or impolite and nothing. It has to be in a very gentle manner.
So how to deal when we don't know the language?
Okay. Now, when we have recently moved into a new place, it is obviously very difficult. It takes time to learn a new language. Till that time, of course, you have to take the help and support of your colleague or your staff with whom you're working, and try to learn the language as well as possible. But the most important part that we all need to understand is that the major component of communication is body language. There are many studies which say that anywhere between 70% and above of communication is body language. So if you practice good body language skills, now these are the things that we need to learn as part of workshops and real mentoring. So it is important, and as I mentioned previously, when you go to the patient's room bedside in the IP, sit down, because when you bring your body in alignment with their body, the body positions are same. That is better communication. And that was just an example. So there are many things that you can do to improve your body language, and which constitute the major part of communication in any setting, not just medical setting, but any setting. So we can overcome a lot of language barriers by positive body language. The facial expression, the tone of our voice, the body position, body posture, uh, all of these things make for good communication. Sunil?
Yeah, Biju, what are your thoughts on taking feedback from the patients about communication, your own
Yeah.
communication?
Yes, feedback from anywhere is an excellent idea, and uh, it's always a welcome idea. Only thing is that many times there are some logistical issues. Uh, of course, when directly asking a feedback uh, may not give you. I am assuming this, but I not most patients may not want to give you low marks, especially if you are caring for them. So it is very important that a totally unrelated third party, something like a social audit, can be involved, and hopefully we will have an honest feedback. We taking a direct feedback from the patient is and would probably give us excellent feedback, but I probably it may be true, but I would rather have an honest feedback rather than a very charitable feedback. So having that kind of uh, environment requires a lot of investment in terms of human resources, etc. It's costly. So to get an honest feedback from the patient without we directly being in any way involved with the process is a costly affair.
Biju, can you, this will be the last question, I think. It's already
Okay.
important. A few sentences on body language.
Okay. Body language, I can just tell a couple of positive body language. One is eye contact. And when we say eye contact, it is the good triangle we are talking about, the inverted triangle between the two eyes and the lips. So that is a triangle. Focus there. And of course, you can rove your eyes around in that triangle. So make eye contact. And eye contact does not mean staring into the eye. It means looking at the face, not looking away from the face, not above, not below, and not to the side, but focusing on a good triangle within the face. Eye contact is very important. Then smile is very important. And as I said earlier, even if you're wearing a mask, try practicing smiling. When you know somebody, when you know somebody and you like that person, a natural smile will come. It is very important to practice a professional smile, and that comes only by practicing. So you can start practicing on your colleagues, smile at the security people, smile at the ward boy, smile at the catering people, smile at the reception people, smile at everybody within the hospital, and then slowly you will realize that it becomes easier. It will come automatically. You don't have to think about it. It will come as a spinal reflex. So anybody you see, automatically you will smile. So it is something that comes with practice. Surprisingly, healthcare professionals, be it doctors or nurses, the smile is in short supply. So eye contact, smile, tone of voice. Now remember, if you have a warm and welcoming tone of voice, that itself takes care of many problems. And if you practice smiling, then you will automatically get a good tone of voice. So if you practice smiling, if you smile more often, you will have a good tone of voice which will come free with the smile. Then the important thing is about body position. That is how one body is placed in relation to another body. If you are a doctor, you're sitting on a chair and the patient in front of you is standing. It is a body position is of inequality. It is hierarchy. So you offer them a chair to sit down, you make it equal, and that improves, and that is a good body language. If you have gone to see somebody in the ward or in the room, you standing and talking to the patient or the family while they are lying on the bed or sitting, again your body and their body is mismatched. So you sit down, you pull up a chair or a stool, whatever is available, you sit down, and then you bring your body to their level. Same thing with children. Children are smaller in size. So it is very easy for us to bend at the hip, bend and talk to them. So don't do it. Sit down or sit on your knee, bend down on your knee, and bring your body in alignment to their body. So there is equality. So whether you are talking to patients in OP or IP, you need to have the body in the same position, which brings equality, which brings more satisfaction. And also, when you start the interview, always lean forward, because that the position of kyphosis is giving an expression. I'm here to listen to you. Instead of that, if you are in lordosis, your spine is bent backward, you are relaxing on your comfortable chair. It shows that I'm the king of this place and you are just a piece. So it creates more distance. So it's very important to start off with bending forward, while not too much, just a little bend forward, showing, conveying, I'm here to listen to you. That is a positive. Uh, and then there are other things like having an appropriate distance and how to touch, where to touch, and all that kind of thing. Lot of things, but I just mentioned a few. Uh, you know, I could go on and on and on. It is endless. Body language is a vast ocean. There is no end to it. So I'll stop there. Sunil?
Okay, thank you, Biju. So I will give you a practical example with body language.
Yes.
So suppose uh, in medical profession, we usually see many patients, and especially in cancer patients, there will be some fungating ulcer and a foul smell, maggots in the wound, etc. So suppose we have a newly joined person, and if there is a patient who has very fungating ulcer with foul smell and maggots, maybe entering into the room of that patient, the newly joined person may show something in his body language, like facial expression, his the body itself may be rigid. The face may be the facial expression may be something which that actually comes without his knowledge. So this is one from the medical profession, and in our day-to-day life also. Suppose we are going in a we are getting transport in public transport and system. So in bus, usually we like to sit in the side seat, isn't it? So what happens? We get into a bus. We have one side seat. We are sitting in that, and after some time, all the other seats are full. After some time, another person is coming, and at the first sight itself, you yourself are telling that, okay, I don't want this person to come and sit near me. But there is no other seat. There is no other way. The person is coming and sitting near to you. So what will happen to you? You will move to the side more, and so that the other person will sit more comfortably. And after some time, what happens? He's sitting comfortably. You will try to adjust to side as far as possible, and when that is not possible anymore, you may turn to the opposite side. So you will be sitting laterally, uh, not looking at the face of the other person. And maybe after some time you will be taking your hand and holding on to the next seat. So all this are telling indirectly to the other person that I don't like you. So this is some body language which you can usually see in our day-to-day life. So I just wanted to mention this. So Biju, I think we will move on to the patient story, which
Yes.
will be presented by Dr. Indu.
Hello, sir.
Yes, ma'am.
Yes.
Okay. Good afternoon, everyone. I am Dr. Indu, working as assistant professor in Department of Oral Pathology at Indira Gandhi Institute of Dental Science, Kodamangalam, Ernakulam. Can we move on to the next slide? So I'm going to present a case of moderately differentiated squamous cell carcinoma involving right buccal mucosa. Next slide, please. So a 52-year-old male patient reported to our hospital with a chief complaint of a broken tooth in relation to the right lower back tooth region, basically in the right mandibular posterior tooth region. So he gives a history of trauma from the broken tooth in the right cheek region, and patient had multiple missing teeth. So one of his main concern was he was unable to eat food properly. So these were the two complaints raised by the pointed out by the patient. Next slide, please. So the past medical history, patient gives a history of diabetes mellitus but he's not undergoing any treatment, any allopathic treatment. He's doing some form of Ayurvedic treatment for the same. Patient has a history of hypercholesterolemia, and for that also he is not under proper medication. So his presenting illness is basically a chronic non-healing ulcer in the right buccal mucosa because of trauma from a carious broken tooth, and the patient noticed this ulcer 1 year back. So initially the ulcer was painful, and now the ulcer is painless. And his personal habits, he's a cigarette smoker for the past 20 years and occasionally chews tobacco for the past 10 years and consumes alcohol. And the patient is partially edentulous since he is having multiple missing teeth. So on examination, there was a chronic non-healing ulcer in the right buccal mucosa. It was erythematous in appearance with well-defined border. Ulcer was clean. Basically, there was no discharge from the ulcer. And there was a white patch in addition to the ulcer, which was actually involving the gingivobuccal complex. And on palpation, the base of the ulcer was firm and indurated. And on examination, there was a palpable right submandibular lymph node. Next slide, please. So since our institution is a private institution, usually clear-cut cases of squamous cell carcinoma are being referred to nearest government institution. But when we are talking about this patient, it was difficult to convince this patient to any form of treatment. So we actually sat with the patient and we actually explained to him the effects of long-standing diabetes mellitus and hypercholesterolemia, and we referred this patient to a physician to make sure that his blood sugar level is within the normal limits. Then only we can do an incisional biopsy from the ulcerated area. And in the first appointment itself, we did a selective grinding of the broken carious tooth in order to relieve trauma to the buccal mucosa. Next slide, please. So psychosocial aspects, he is married with 2 children and he is a single earning member of the family. He is from a middle class Christian family. But the positive thing was that he has got a good moral support from a brother-in-law and family. And he frequently attends meditation programs which are organized by the church. And the patient doesn't believe in any of the allopathic treatment modality. And he actually believes in something called as chelation therapy. And this patient believes that the only cure for all his ailments is can be done only through chelation therapy. So it was actually difficult for us to convince the patient about his present medical condition. So that was a difficult task for us. Next slide, please. And so, as I told you, this patient was referred to the physician for treatment of diabetes and for the management of cholesterol. And we did incisional biopsy once the blood sugar level was within the normal limits. So it was diagnosed as a moderately differentiated squamous cell carcinoma. So we referred the patient to a higher center. And since the patient had relatives in Calicut area, he underwent further treatment in MPR Cancer Center, Calicut. So from there, we came to know that the patient had to undergo heavy mandibulectomy with selective neck dissection, followed by radiation therapy. Next slide, please. So for us, being in a private sector, it was we don't see much cases of frank malignancy. We get to see more number of odontogenic tumors, salivary gland malignancies, and potentially malignant disorders. So so this is the first time that we actually try to communicate this bad news to the patient. So it was actually a Herculean task for us. So basically, we came to know that he has got a good moral support from brother-in-law and family. So before communicating this bad news to the patient, we took the contact number of brother-in-law and his elder son. Elder son is working in a private institution as a private firm, private company as a trainee. So we actually try to explain about the medical condition to the brother-in-law and his elder son. So they were actually mentally prepared, and the very next day we called the patient to our hospital, and we communicated about the diagnosis part to the patient, and we explained to him about the treatment modalities, and about he was actually very much concerned about this about the aesthetic appearance after the surgery part. So we try to communicate to the patient to our best regarding the various treatment options available, and regarding the financial and moral support, actually we actually try to communicate to the patient, like we actually motivated the patient that within a span of 6 months period, his elder son will also he will also be able to financially support him. And basically the patient is running a bakery. So we actually motivated the patient that like when he go for treatment, his wife can actually take care of the bakery and other things. So like he was more he was like more okay, and he was willing for further treatment. And we gave from the first appointment day itself, we gave the patient an anti-tobacco counseling. We actually counsel the patient regarding the harmful effects of tobacco and alcohol. Next slide, please. So to summarize with, it was a 52-year-old male patient reported to our hospital with a chief complaint of a broken tooth in relation to mandibular right posterior tooth region. There was a non-healing ulcer in the right buccal mucosa. And a patient also complained about multiple missing teeth. He was partially edentulous and he was unable to eat food properly. So he was diagnosed with incisional biopsy from our institute as moderately differentiated squamous cell carcinoma involving right buccal mucosa. Later on, he was referred to MBR Cancer Center and he underwent further treatment. The sad part was that the patient succumbed to death following metastasis to lungs 1 year back. But what I wanted to discuss was that this was the first time as a junior staff, I was also involved. I was also a part in breaking the bad news to the patient, and we were in constant touch with the patient when he went for treatment to MBR Cancer Center as well. Like his son used to update about all his treatment progress, and he came to our institute for palliative dental care. And 2 years back, we had organized a small program on National Oral Pathology Day on February 25th. And we had invited this patient as a special invitee. And he, as a cancer survivor, he actually explained about his personal experience. And it was actually a good experience in my professional career. But the sad thing was that he succumbed to death following mets to lungs 1 year back. Next slide, please. So the points that has to be discussed today is breaking the bad news. And one thing is that oral cavity is an area where we can actually diagnose potentially malignant disorders and frank cases of malignancy at the earliest. So it is our responsibility to actually educate the patient regarding the risk factors of oral cancer. It is not only tobacco, but chronic irritation. A sharp tooth can always be an added risk factor for the development of oral cancer. Thank you.
Thank you, Dr. Indo.
Thank you, sir.
So the two things which I think we'll discuss is importance of early diagnosis and the risk factors for oral cancer. So breaking bad news, we will discuss if we have time, because we are going to cover it in the next class. Are there any oncologists in this group? Anybody? Oncologist? No? Okay. So maybe the dental surgeons other than Dr. Indu.
Hello, I'm
Yeah,
Dr. Khaled. I'm not
yeah,
an
Dr.
oncologist,
Khan.
but I'm a general
Yeah,
surgeon.
yeah,
But the
yeah.
importance of early diagnosis is always there in surgical practice, whether it is in oral surgery or anywhere. The importance of early diagnosis, even when we teach this way, any abnormality found by the patient, whether it is a bleeding, whether it is a swelling, should report to doctor and don't go to this. For example, he was not willing to go to an allopathic doctor, and then he was possibly was taking other non medical means. That is up to him, but the importance of early diagnosis is always there wherever you go. Whether it's an oncologist, I am a general surgeon. I'm not an oncologist, but we have done a lot of surgery, oncosurgery. But I am not a qualified oncosurgeon. But the importance of diagnosis is always there, and the risk factor of oral cancer have been repeatedly told. I am working in a hospice presently. I see every day the oral cancers only. All are gutka and tobacco. We keep
Yes,
on
sir.
hammering them, but then the practices do not stop here. That's all. Thank you.
Okay. Anybody else? Anybody else? Okay. So we know that the chance of curability is also more when the patient is diagnosed in the early stage. That is general for, as Dr. Kale told, for any patients with malignancy. So it is important to find out the um, problem at the earliest. And we know that in India, many cancers are detected at a late stage, so that the chance of cure is less.
Yes, sir.
So, what are the risk factors for oral cancer? Dr. Indu, you can tell us about that.
Sir, apart from tobacco, the main culprit, the chronic irritation, trauma is also an important risk factor for oral cancer. Apart from that, nutritional deficiency, and it is very important for us, being a being a doctor, we should as I have put it in the slide, mouth is a mirror of your body. So like whenever a small change occurs in the oral cavity, we can actually easily notice, because we need oral cavity, especially while having food and all. If we have any burning sensation, it will strike us at the first stage itself. So it is always better to consult a dentist whenever we have any such problems, so that we can detect like potentially malignant disorders at an earlier stage, so that it does not progress to oral cancer.
Okay, so what are the precancerous lesions
So
in the oral cavity?
So we get to see more number of, basically textbook says a lot of pre-malignant lesions, but from my experience, the majority of the cases are leukoplakia, erythroplakia, then erosive lichen planus. Lichen planus is more common in females, and stress is an important factor. So erosive lichen planus cases are especially more in Kerala, that too in northern Kerala. What we have noticed. Then apart from these are the three main potentially malignant disorders, sir. Apart from that, there are many lesions like discoid lupus erythematosus, etc. But like we see, majority of the cases will be erythroplakia, leukoplakia, and erosive lichen planus, sir.
Okay, so you said that it is erosive lichen planus is more in north. Why it is like that? Any idea?
Sir, actually, even I don't have an idea. When we were doing our post-graduation period, actually, we had a forum for this lichen for actually this discussing cases of lichen planus. So in that we came to know that more number of cases are being reported in northern Kerala, sir. I don't know the reason, but it has got a familial history as well. Like in many cases, mother is having and the daughter is also having same problem of erosive lichen planus. So I think we need to do more studies regarding erosive lichen planus.
Okay, thank you. Biju, do you want to make any points?
First of all, I would like to congratulate Dr. Indu for that excellent presentation.
Thank you,
It was
sir.
very comprehensive. It was very clear. And from what I understand, you did a great job of communicating with this person. And the importance of, as I always say, importance of communication is that you give them a chance to understand what is going on and then take decisions based on the information that they have. So it is an informed decision. And as a doctor, you help them choose what would be the right way of going about it. And the most important thing that I took away from this was, despite this person's having a certain belief in non-modern medicine as a healthcare what you call options, he eventually accepted modern medicine practices for healthcare. Now that would have happened only with the effort that you and your team put in, and that changed his mind and accepted modern medicine practices. So even if it was perhaps little late in the day, that definitely isn't your fault. It is because the person was under that impression. And I had earlier said that we have to accept people as they are and respect people for who they are. And if that is their belief system, that is their belief system. But when they come to us, we can always try to make an effort to get them to see a different point of view. You took that effort, they did see a different point of view, they went ahead with it, and probably that helped them live a better quality of life for some more time. And that is to be applauded. That effort has to be applauded. We may try and fail, there is no shame in that, but not trying is quite shameful. So you tried, you made the difference, and I applaud you for that.
Thank you, sir.
Congratulations.
Thank you, sir.
Sunil, that's all I would have to say about
Yeah,
the presentation. Yeah,
okay.
I think we are
Anybody else
overshooting time
want to
also.
comment on this? Yeah, last comment. Anybody else? Okay, I think there are no more comments. I think what we have to learn from this session is that communication, anybody can learn it actually. So it's a learned skill. So if you practice, you can become a good communicator. And when all of us came into the field, we knew the importance of communication only when we did our post graduation, and then we actually started to communicate the people with the principles in mind, and then only we could make our communication better. Please keep in your mind the basic principles of communication, and also understand that it is for your purpose to become a good communicator, because you will get more patience, and there are a lot of advantages if you are a good communicator. So it's for our purpose. Please keep it in mind. So thank you, Biju, for a wonderful presentation. And thank you, Dr. Indo, for a very good patient story. And uh, thanks everybody for participating in this session. Thank you. It's over to
Thank
Arun.
you. Thank you, Doctor. Thank you, Sunil. Thank you.
Thank you,
Dr.
Biju sir. Thank you,
Thank
Sunil sir. Thank you, Dr. Indu, and thank you. And last part of communication is feedback. So I'm sharing a feedback link. Please do it now.
Yeah. So may I take your permission and leave because I have
Yes, sir. Yes, sir. You can.
patients to see. Okay, then bye, Arun. Bye.